Yeah, so I'm going to talk about complex distal humerus fractures. I think there's another title in there that was the wrong title. No pertinent disclosures. Two things really make elbow fractures challenging. And one of them you can't do much about, biology, and the other one's anatomy. You can know the anatomy. Biology, there's a high percentage of patients, no matter what you do, how good you make that x-ray look, they're going to get fibrosis and arthrofibrosis, and you're going to be not happy with your outcome. But if you kind of get the anatomy back, you're going to minimize the biology effect. So it's all about anatomy in the end. I love that. You have to be able to see it. You have to get good views in the OR. These are from the AO website. You see on the lateral. The lateral is always hard, especially with a fracture, to recognize what's going on, whether the cornoid, the radial head, the PUDA, which has been written up recently, is much more important than it ever was, and figuring out where it is on that lateral. And this is a view that most people don't talk about. It's sort of an oblique. You can do a medial lateral oblique, but this really shows you that number 2 and 3 lines where the trochlea is and whether you've got that reduced. And when it comes down to it, that's all you need to get reduced, or the most important thing you need to get reduced at least. So anatomy, we can talk about it all day. People don't like to do elbow because of the anatomy. It's really just a hinge joint. It's off a little bit on both the varus valgus and in rotation, and that's what people get in trouble with. It's 48 degrees off on each view. So if you look at it here, that tilt is about 4 to 8 degrees. You need that in order to get back your normal range of motion, particularly supination and pronation. So AO talks about the triangle of stability. I don't think it matters where you put your plates. They're all stable now. All modern plates do a fairly good job of this. You put your plates where it's the best. You go 90-90, either medial or lateral, or go 180. It doesn't really matter. Most of the new systems have locking screws in them that help you fix those small little pieces on the end. So classification, we're really going to talk about complex right now, but these kind of fractures and what to do with them. It's more of a practical approach. The classification system breaks down for me in the complex fracture. Basically, this is the classification I use. All pieces are either easily reducible, some bones missing, some cartilage missing. You can't really see where the cartilage is, and is that an elbow? So those are the 5 categories we're going to kind of talk about. And there's options for all these, and we're going to talk about the approaches, what to do with the pieces, where to find the new pieces, and what pieces of metal to use. So the goals are the same always. Implants are determined by the fracture pattern. You use just as much implants as you need to get early range of motion without stripping too much. Remember I talked about the biology, so you don't want to stir up the biology too much, so put as little on as you can, but you need to be able to move the elbow at 10 days. The bag of bone technique, I rarely ever use this anymore. There's obviously some patients you do use it on, maybe distal impacted fractures in the elderly, but otherwise there's other options. So the approaches, it's been 25 years since I've done a chevron osteotomy. I do not do osteotomies of the ulna. There's a lot of people that complain about them, surgeons amongst them, but patients in particular, there's somewhere in a 44 to 60% hardware removal rate and a very unhappy group of patients generally. Some people go, oh, all their osteotomies go great. I just put a plate on them all. They all love it. I don't really believe that after doing that. So it also makes it hard to do a revision total elbow, which is where some of my patients go. And so I never do it. I know never say never, but I never do it. Okay, I was very clear about that. So reduction seems to influence outcomes, so the best way to get a reduction is to have the right approach, right? So you need to have the right exposure, and choosing the exposure that fits the fracture pattern, one of those 5 things. So these are basically all the approaches to the elbow. So they're all through the back. Either do a tricep split. Dr. McKee wrote an excellent paper about the tricep split, showing that you can reduce almost anything through it. I use almost exclusively the trap flap. Mori medial approach, the third one, that's what Mori and Coonrad came up with to put total elbows in. And it's just kind of a trap flap without the lateral side. And then there's the electron osteotomy, which I talked about and I'm not going to show. Paratricipital and the tongues. The tongues are used more in Europe than North America, so we probably haven't seen one of those recently. The trap flap, this is what I use. It's a posterior approach. The flap's lifted off. You keep the triceps and the anconeus intact. Theoretically, there's a blood supply and nerve that runs through that and keeps the anconeus robust, so you don't lose the anconeus and you don't feel the hardware through the wound afterwards, so it's really nice. And it goes down about 15 centimeters, so it's a little longer incision, but you just put that back on with fiber wire onto the ulna, and it seems to work out well. Positioning for all these patients, I usually use lateral decubitus. Prone is possible. You see it in some of the textbooks. It's not really popular for the anesthesiologist. Supine is used sometimes if you have a polytrauma patient, you have no choice but to go supine. I hang the arm over a post. I don't usually use this approach. I prefer a sterile bump or a bone foam, which I can take out in case I have to convert to total elbow at some point. It's just easier to set up. Sterile tourniquet, don't usually use the tourniquet, but sometimes we have it on just for in case the resident puts a K-wire through the front of the arm. I've seen that happen. So what do we do? If all the pieces are really easily reducible, you just do a split or a paratricipital. You need to get the pieces, recognize the anatomy on the x-ray. This is one of those fractures. There's 2 at least big pieces, maybe 3 in there. You can probably get it through the both sides fairly easily. You put the hardware on like you like. You can't see in the front of the elbow. You can see there's some loose pieces of bone that resulted in HO at 2 years in the front, but it didn't really impinge on the range of motion, so I was fairly happy. You can see that oblique view in the middle where you can see the trochlea actually got reduced, so that's a nice view to have, I talked about before. I usually use the trap flap when I'm doing these 3 approaches, or the approaches for these 3 problems. So if some bone's missing, some cartilage is missing, or you can't really see if there's any cartilage, I use the trap flap. It gives you 100% vision on the elbow. You do an osteotomy at the end. You see the ulna arrow. Take off about 25% of olecranon. You can see 100% of the joint, and you can actually operate in the front of the joint as well. And you can see enough to get a really nice reduction of it easily. If some bone's missing, you're still trying to get this kind of reduction, but what bone is important when it's missing? Really, you only need those 2 arrows, what's shown in the 2 arrows to get elbow range of motion. You don't need any of the rest of that. The problem is you want early range of motion. So you can get those 2 pieces reduced in midair. That's not really helpful, but that's what you're going for, is getting those 2 pieces of bone reduced and getting that angle back to normal. So some bone's missing. Here's a patient with an open fracture. I might do this differently now. I might use a fibular allograft because this patient was missing a little bit of bone on the column. Here's a young patient. Same thing, a trap flap. You get it reduced. This patient is obviously missing some bone, extra-articular. I can see here the posterior lateral plate is too lateral, so I repositioned it. You can see where the screws will be in the front of the joint. It's very important to get a nice lateral x-ray in the OR when you're doing it. And then I just used a bone bank allograft for that particular defect, and that allowed me to get the elbow reduction better. See the posterior lateral plate now in the right spot. There's an 8-year follow-up on that patient. You can see the allografts well incorporated. So what do you do when there's some cartilage missing? Well, that's a bigger problem. You have to really realize where it's missing from. That's really important. So you can see a good exposure here. This is from the ring publication. You can use whatever classification you want. Just realize that there's fairly constant pieces that result from fractures of the distal humerus. How do you reduce this? It's really hard with the conventional plates, so I usually use something different. I usually end up using some older technology, which is K-wires. You might have to use multiple modalities here, bone graft, get out the length, and then recognizing where the cartilage is and putting multiple K-wires in sequentially, and I do it like this. So if I have number 5 as a constant piece, I'll put K-wires through, cut them off, realizing they're going to stay in for life. And then perch number 4 on top of it, reduce that, then cut the K-wires off from 4, perch 3 and 2, and keep going across the elbow like that with small K-wires that stay inside the bone. You're not going to take those out. I usually use small threaded K-wires, 0.6 millimeters. Sometimes you have to get from 1 to 4, and that's hard. So here's a 6-year follow-up x-rays. He's now 14. We tried to contact him for a study. He's 14 years out, and despite the HO, he just said, yeah, I'm doing fine. When I need a total elbow, I'll contact you. So he was happy, apparently. Dermoplasty was an option I used a few times when I started practice. I never took a picture of it because I figured I'd be doing a lot of them, and I haven't done one in 30 years. So it was good for very young, active patients, laborers. I had 2 roofers get it. It did very well. I usually use abdominal dermis, or I used to, rather than from the arm. It closes primarily. You don't have to worry about it. So what do you do with these patients that you kind of go, what cartilage? Here's a 38-year-old female who fell down. The x-ray is not bad, but when you do the other x-rays, not looking that good. CTs show you have a lot of cartilage pieces, sort of like that ring classification paper. The secret here for me is doing the trap flap and taking down the LCL. So you can do the trap, then you take down the LCL, and you can book the arm open on the ulnar nerve, and you can see, not only see 100% of the distal humerus, you can operate from the front. And you can put in screws like that. You see that one in the trochlea, front to back, that you can't do with any other technique. And then you just repair the LCL at the end. And then the last kind of approaches are for those ones, is that an elbow at all anymore? And you're left with the options for either total elbow arthroplasty or an allograft. Here's a patient I did an allograft in. I do use allografts. Allografts had a bad name because Anakin's first paper had a 26% infection rate. It was all comers, all tumor patients, all immunocompromised. So your infection rate is really not that high. And you can reconstruct that fairly well in a young patient. Expect that to move on to either an elbow arthroplasty or another allograft in 10 years. Don't do a hemi allograft. They don't last. The reason these last is because there's no nerves to the joint. They'll last even if they have arthritis. Another example is at an elbow. The last thing we're doing is somebody tried to fix that. This was sent to me at 3 weeks post-op. And basically, to me, that's a non-starter, and they end up with something like this. Is there any good elbow arthroplasty option? I don't think so. One that lasts, no. One can be used under 60, no. We need a little bit better technology for that going forward. Thanks.